My name is Dr. Ho Kay Woon from Singapore National Heart Centre. I'll be co-chairing this session with Dr. Ing Wen-Xing from Taiwan. Together in this panel, we have Dr. Wasin from Thailand. We have Dr. Savraj, he will be a cardiac surgeon from National Heart Centre. We have Dr. Chong Ki-Soon, cardiac surgeon. He will also be the chat moderator for this session. And none other than Dr. Kentaro from Japan as well, who will be joining us. We have an echocardiographer, Dr. Rizwan from Singapore. Dr. Poses is from Philippines, interventional cardiologist who does TAVI as well. Dr. John Yap, my partner in crime in Singapore, we do TAVI together. And Dr. Eric Eckhout from Switzerland. So it's an exciting session of live TAVI. So just for housekeeping rules, if there are any questions, of course, there are mics that are available throughout this auditorium. However, we will also be flashing out the QR code. So the QR code is being flashed right now. You can scan the QR code, and that will give you the ability to pose the questions. Dr. Chong Ki-Soon will be monitoring these questions, and we will try to address these questions as soon as the time is appropriate. So we're figuring out technically how to bring out the QR codes. And can I just check whether the, yeah. Okay, so this is the QR code. So if you can whip out your cell phone, scan the QR code. This is the Pigeonhole website. This will give you the ability to pose questions, particularly so if you're very reserved and shy. Okay. Or you can just go to the mic and ask your questions. So can I check whether the live site is ready, Apollo, whether it's ready, whether we can switch to the Apollo live site? Okay, we can go ahead. Hello, good afternoon, Dr. Vilu. Can you hear us?
Good afternoon. We can hear you very well.
Welcome. Thank you for joining us in Sing Live. Before you introduce your team, we have a great panel. I'm Kay Woon from National Heart Centre. We have Dr. In from Taiwan, Dr. Wasin from Thailand. We have our cardiac surgeon from Singapore, Dr. Savraj and Dr. Ki-Soon. We have Dr. Kentaro from Japan. Dr. Rizwan, again from Singapore, echocardiographer. Dr. Poses from Philippines. Dr. John Yap from Singapore, and Dr. Eric Eckhout that is making up the panel. So eagerly awaiting the live case, I'll hand over the time over to you, Dr. Vilu.
Thank you very much. That is a very great, extreme panel. So let me introduce my team. I am Dr. Sengottuvelu from Chennai, Apollo Hospitals, India. So I have my colleague, Dr. Muthukumran, who will be my second operator, Dr. Sendil, and we have for echocardiogram, Professor Chandrasekhar, and we have a nurse, Hanu, and a senior technician, Andrew, and we have anesthetist, Dr. Karthik. So let me now introduce the case now. So go ahead with the next slide, please. So this is a 61-year-old male. He has known hypertensive and also has pre-diabetes. So his symptoms in the last 1 year has been progressive onset of dyspnea, which is gradually increasing over 1 year. But he's been a known case of chronic liver disease, and he's had a history of esophageal varices, for which he had ligation. So now he's been diagnosed to have severe aortic stenosis since 3 months, and symptoms have been progressively increasing. Then we evaluated him, and his STS score was 2.38, relatively low STS score, but he was highly frail. His frailty score was 12 or 15. He was quite a well-built gentleman with a body surface area of 2.01. So with that, he was planned for discussed with the heart team, and it was discussed, and the heart team decided that this is a young patient, but he should be considered for TAVI in view of the liver disease and history of bleeding with varices, as well as uh, considering that this patient has some amount of ascites and liver disease. So it is decided by heart team that this patient should go for TAVI. But considering the young patient, we discussed and planned to see how to do a TAVI in a young patient. So next slide. So it's basically his resting electrocardiogram showed no conduction disturbances. It is normal. And next. And his echo showed severe aortic stenosis. We'll have a detailed echo commentary from Dr. Professor Chandrasekhar, please.
Good morning. I think here, I hope all of you are able to see the video there. You're seeing a parasternal long axis view, severe LVH, and you can see the extensive calcification involving the aortic valve and the aortomitral curtain as well as the posterior leaflet. And if you look at it, aortic root itself is asymmetric sinus dilatation. Non-coronary sinus is more ectatic, sinotubular junction is effaced, and there's also basal septum which is protruding in. And between the annulus and the basal septum is about 7 millimeters. Then let me show you the short axis view. These are the measurements. Here is the LV outflow. Annulus diameter is about 20. As all of you know that the annulus is not circular, so it's oval. And some areas we got about 22, and some we got about 20. So its average one comes up to around 21.2 or something like that. And sinus level is about 32 millimeters, and sinotubular junction is 26, and ascending aorta is 28 millimeters. And this is a short axis view of the aortic valve. As you can see, is a heavily calcified aortic root. Of course, the gains are a little bit high, but nevertheless, you can see the trileaflet valve doesn't move well. The non-coronary cusp is the one which is a little bit more calcific, and it doesn't open that valve. And severe LVH you can see, and mitral valve and LV function is normal. And this is the aortic valve gradient. I think before that I'll show you its four-chamber view. So here is the four-chamber view. I mean, this when he's lying down, as Dr. Sengottuvelu pointed out, his BSA is high, and so nevertheless, LV size is fine, LV function is pretty good. Look at the extensive calcification involving the aortic valve, aortomitral curtain, aortic root. And the maximum gradient what we got was around 72, but if he was, when he was on left lateral, it would have been a little bit more, mean gradient of 43. The calculated valve area was about 0.8 to 0.76 to 0.8 square centimeters. And overall, other than that, we didn't find any other issues with the cardiac status. The LV function was normally EF around 65 to 70%.
Thank you, Dr. Chandrasekhar. Thank you very much. Now, can you have the slides again? So can you show the slides again? So this patient was discussed and then proceeded for CT scan. And the gradient what we got was quite, mean gradient was around 60. So the CT, again, can you show the next image? So it was a tricuspid valve. There was not much of this. I can see some specks of calcium in the annulus. Next. So if you look at the LVOT, was the aortic annulus diameter was 22.5 in repeated measurements, and the LVOT was the average diameter is almost similar to the annulus diameter. Sinus of Valsalva was around 30, 30.8 and 30.1, so quite relatively large. And the next slide. So the coronary heights were quite, both sides were 14 and 16, the left and the right, so quite high coronaries. Next slide. So the aortic angle was quite favorable. Next slide. The peripheral anatomy was again suitable for TAVI. The femorals were 6.44 and average of 6.9. Iliacs was 6.9 on the right side. Not much of tortuosity, not much of calcium. So next. So to summarize, This is a young man with severe aortic stenosis, with class 3 symptoms, with minimal coronary disease, with history of liver disease,
Yesterday.
with a relatively low STS score, and frailty index was high, and was decided for a transfemoral TAVI, and the CT showed a tricuspid aortic valve with good peripheral access with moderate aortic valve calcium. So next slide, please. So our plan is to, in this patient, we want to do conscious sedation and with ultrasound guided femoral access, single access with a single radial access. And this patient, we don't do a TE. Again, this patient also has a varices, so esophageal varices, had history of varices. So we plan to use a single proglide based closure. Maybe if required, we'll put in an angioseal. And in the case, the valve choice was again debated, and considering that this patient was a young patient, we decided that we should give a good hemodynamic result as well as long-term access for coronaries and no patient process mismatch, and also preferably no pacemaker. So with all that consideration and also a valve which is easily accessible coronaries, we decided for accurate neo valve in this case. Next slide. So our plan is to use a 14F eye sleeve and a Safari extra small wire, and we want to use a pacemaker for balloon dilatation. I've used a 20 millimeter balloon. Here the perimeter derived diameter was 22, so we decided to use a 20 millimeter balloon. We don't have a 21. It's only recommended to use 1 millimeter less. And here again, the sizing of the accurate neo was based on the perimeter derived diameter, which was 22.5, and the perimeter was 70.8. So if you look at the charts, 70.8 is a borderline between the small and the medium valve. So considering that we always want to oversize the valve, and also this is a big, well-built person, so we thought we should put a bigger valve for this patient. So next slide. So with that, I think we can have the discussion, and then I can add more if required. Thank you.
Thank you, Dr. Velu. It was an excellent case presentation and lots of discussion points. As we discuss, for interest of time, please have your team work on while we discuss with the panel. Maybe just take the elephant out of the room. Relatively young patient, STS score 2.8. We do have surgeons in the panel as well. First question may be directed to the surgeon. Would you operate STS score 2.8?
Get the eye sleeve.
So STS score is 2.8, but we got to assess the patient because with chronic liver disease and cardiac surgery, there's a correlation of high risk, poor outcomes. So we need to assess well, and with recent varicose bleed with ligation, we are worried with the full heparinization, what will happen on table, what will happen post-operatively, and whether this patient with chronic liver disease will be in the best shape pre-morbidly before the surgery. I think just looking at the history, I think most cardiac surgeons will agree that in today's day and age, if TAVI is an option for this patient whose life expectancy is not going to be the same as the general population, I think TAVI can be a good option. And yeah.
Okay, thanks, Dr. Sivraj. So if surgery is not suitable for the interventional cardiologist, what would be a choice of a TAVI platform? Maybe we could poll some opinion. Eric, what in your country, if you had such a patient, would you do?
Well, this valve is available and used in our country as well as the competitors that are, of course, Edwards, Medtronic, Allegra valve. They're all available and used over the country. The differences that remain are probably at our side. You would probably pace on the wire because you just avoid one more vascular access. And we also still use conscious sedation with the anesthesiologist, but more and more centers now even step away from anesthesiologist. Just do it yourself, give a bit of fentanyl, and that avoids the catecholamines that the anesthesiologist gives, and that triggers pressure variations over the procedure. So we haven't done it yet, but that's maybe the only difference, yeah.
Thank you. So you've heard Eric as well as Selvraj, the surgeon's comments. Maybe we pause here and catch up with how you're doing. I see that you have the eye sleeve sheath that's put in. Maybe can you talk us through the features of these eye sleeve? Because not all of us would have experience with this accurate Neo2.
Okay. So we have taken a femoral axis and we have taken a radial axis. So first we had done a iotogram. Can you show the iotogram now, please? So this was RAO 15 caudal 18, which is a coplanar view, which was very good. And the coronaries, you can see it's normal. So now we have taken the eye sleeve. Eye sleeve is a 14F sheath from Boston. It's an expandable sheath. And so we can take in the valve, like of all the expandable sheath, I like the sheath a lot. It's very flexible and also it's trackable and there's no bleeding in the sheath. It's quite a good sheath. So and we can take the accurate neo valve through this eye sheath. So now I'm going to try to cross the valve. So this is which catheter? AL.
What catheter are you using to cross the valve?
AL1, is it? Yeah. It's AL1, yeah. It's AL1.
Just to pull across the panel again, how many have actually experienced using this accurate Neo2 in the center? Dr. Poses, Kentaro, Eric. So Europe and Philippines do have some experience, and Dr. Watson in Thailand. No, we don't have this experience in Singapore, but we do have that in the panel and perhaps in the audience as well. Okay, so crossing. So this is a tricuspid valve. Okay. Very nice crossing.
So the other important thing about this valve is it's very important that it requires predilatation in 100% of the cases. That is because the radial strength is much lower and you need to prepare the valve, otherwise the risk of pop-outs are very high in this valve. So it's particularly important to more aggressively predilate. So we use a perimeter-based diameter, slightly lower than that to predilate, so little bigger size balloon for this predilatation. And very often may not require post-dilatation, but predilatation is a must.
Is it your routine usually to predilate with the rest of the other platforms?
Yeah, as you said, most of the time with a balloon expandable valve, about more than 80 to 90% we do a direct deployment unless it's heavily calcified or there's a bicuspid valve. But for this valve we use for every patient. So I'm using an extra small safari wire. And very often in our country, we see very small ventricles, and we are comfortable using an extra small wire. And the position of the wire is again very, very important for this valve. The wire should be quite deep inside, and it should not be freely floating as well. So it's very important to place the wire nicely, and the curve of the wire should be pointing upwards. That's why it's important for every case of TAVI, but in this, particularly for this valve, it's very important. That is because the valve can again move upwards if the valve is if it is inverted, the wire is inverted. So if you don't have a good wire position, it's always good to put the pigtail again and get a good wire position. So here we use a 20 millimeter balloon to predilate. Okay, pacing on. Pressure.
You're going to be finished
yeah.
before time. Take your time, Maybe one of the advantages of this valve is that you can use it in patients with aortic regurg with less calcium. So it's a valve that is a good indication for that to mention.
Well, in addition to the hemodynamic benefit, are there any other advantage of using accurate neo, such as coronary protection or reduce of pacemaker implantation?
People say that you have less pacemaker implantation. That's what people say.
Yeah, you have less pacemakers and you have good access to the coronaries. Can you start pacing, please?
And the other, I saw the study mentioned that using of acroneal can avoid future
Stop pacing.
valve deflection on the TAVI in TAVI scenario.
Right. Well, we don't have the evidence yet, but from its design and from our experience, I think the advantage of the acroneal too is that for horizontal aorta, for low coronary height, down to like 8, even we have some cases with 6 or 7 millimeter. It's designed for those kind of anatomy, and it's probably one of the best self-expandable one with future coronary access friendliness.
Keep the wire inside. So the downside is probably the one the valve for more than 27 millimeter annulus, you can't use this valve, as well as this extreme calcium or bicuspid valve. You have to be very cautious. Okay, so let me take the valve in. So you can show here. So there's an insertion aid. This helps to insert the valve. And we are keeping the knob at 6 o'clock position for commissural alignment. Can you show that also down, please, here? Okay, I'll show it to you now. So let's take 3 pushes, and then I can remove the insertion aid. Now you can focus here, please, down. You can show that 3. Yeah, now you can see that. Can you show down, Andrew?
Yeah, we can see the handle, so we can see
show the wire also. Show the wire, please. Yeah, good. Let's keep it like that. Yeah. So it's pointing down.
So it's similar to an expandable sheath, this eye sheath. When the initial device goes in, it expands. So you have a little bit of resistance, do you, the initial push?
Yeah, exactly. You have a little bit of resistance when you push through this expandable E-sheath, and then once you get out of the sheath, it's quite very free and smooth. So let's go to the coplanar view, and I'm going to put it right, the marker just in front of the pigtail, upper point of the pigtail, just to start for the commissural alignment. So can you show down now? Can you focus on the valve, new valve commissures, please? Correct. So here, if you see above the marker, you have the 3 new commissures, and you can see 2 are pointing towards the left of the screen. So in a coplanar view, we want to have all 3 equidistant. So it's not for commissural alignment. Now we have to make it equidistant. And for that reason, we have to do a clockwise rotation. If you have 2 on the outer curvature, we have to do a clockwise rotation. Again, you have to hold the handle here, make sure you don't touch the knob, and do a clockwise rotation. And then you have to wait for at least to push the wire a little bit inside. So make a turn at least 180 degrees to see any differences there. So it's getting better. Yeah, it's now better. So I'm going to hold it like that and release it. Now it's better. So yeah. So now we can even check in the cusp overlap view. Go to the cusp overlap view. It's RAO, more RAO. More RAO and caudal. What's the cusp overlap view? Go to that view. Yeah, show the commissures again. So, yeah, I think it needs a little bit more rotation. So come back to the coplanar view. So I think commissural alignment is very important for this particular patient because the reason one is for the coronary engagement, and the second for future TAV and TAV, you need to have a good commissural alignment if you want to do a TAV and TAV in the future.
Yes, I agree, because particularly so in TAV and TAV, this is going to be a supraannular valve platform.
Yeah.
The risk plane is going to be high, and we may need to consider leaflet modification. If the commissures is directly in front of the coronaries, the leaflet modifications will not work as well. So you rightly pointed out.
Can you do an iodogram, please, now? Small test. So the pigtail is in non-coronary sinus. So picture, small picture. Yeah, come to the coplanar view, please. Come to the coplanar view.
For those with experience, how's the commercial
What's the view?
alignment?
Huh?
This is coplanar view.
Yeah.
Well,
Yeah,
it's,
this is, okay, this is a coplanar view. Take a picture there,
it's actually one of the valves that it's
You can
easiest to do a
Push the
commercial
pigtail.
alignment.
Push the pigtail.
But sometimes we cannot rotate them as we like.
Test,
But it's
test.
easy to see whether it's commercial aligned or not.
Okay, Dr. Velu, can you talk us through about the positioning? What are you looking at in terms of determining the depth of implant?
Okay, so we can see that they have a central marker, which is a square marker. So it's very important to position the lower border of the marker in line with the annulus, the lower border of the pigtail. So I'll take a picture again because it's a little bit moving. So the valve, if it is moving a little bit, then we can also do a slow pacing, inject.
Yeah, I would suggest to start some pacing at 120 already to stabilize
So
a
the
bit.
valve is moving a lot. So we probably will pace at 120, yes, 120. And you can see the pigtail is exactly not in contact with the lower part of the annulus. So, okay, now give a small test. I think I'm happy with this position. It's more stable now. So it's important to keep the last movement should be a forward movement. Test again. I think I'm happy with this. So let us do the first part deployment.
Okay,
So we'll do the knob
focus on
1
the
is being released
handle.
very slowly.
So this valve
Okay,
release
wait,
from
test.
top down.
Test, okay. Yeah, so it's going good. So continue.
You see the stabilizing arches that are
Good,
deployed.
continue. Little hard stop. Yeah, okay. Now you can take a small injection again. Okay, the pressures. Okay, we have the monitor there, pressure. Okay, good. We're not seeing the pressure here. Okay, good. Okay, now we are fine. So we'll do a rapid pacing and show the last picture again. So we'll release a knob 2 and can you show that? Yeah. So it seems to be very stable. We don't have to do pacing. We'll just do go ahead. Come. Yeah, slowly remove the pigtail, please. Yeah, take it out. It's good to take the pigtail out. Okay, go ahead. Go ahead. Yeah, go ahead. No, go ahead. Go ahead. Okay.
So this is
You can see that now the knob 2 is released. Okay, save that. Save that.
Okay. Can
Now
slow
I'm
down the
removing the.
pacing.
So it's important to keep the wire in position because, again, reaccessing the ventricle is sometimes difficult with this valve because it's got wide struts and. Yeah, recapture it. We'll come to some more. Yeah, go ahead. Yeah, fine. So we have to reverse what we've done before. So the knob 2 first, and then the knob 1. Yeah, push the wire a little bit inside. Yeah. Okay. Not. Push the wire. You know.
It's a wonderful deployment. So we
So
eagerly
stop pacing, please, and then we will do a stop pacing. Yeah, now we will take a picture and see before we do an iodogram. We'll check. Come, show the pic. Yeah. Ready? Iodogram. Valve is in looking good position. You can see that the depth is fantastic, and I'm very happy. There is no AR also. So actually, the deployment location is looking very good.
looks excellent results. So even though this is a supraannular TOR valve, you can see that compared to the rest of the self-expanding platform that's available, there is actually strut-free. So the top part of this longer platform in the aorta can easily allow coronary access. How would everybody think about the deployment as well as commercial alignment? Happy with the deployment and results?
Pressure.
So far, everybody agree that it's an excellent demonstration. Congratulations.
So thank you. I think the objective here is to make sure we have a low gradient, but looking at the frame, it looks like very well expanded. So, we look at the gradient and decide whether we need, and also the valve, any regurgitation to decide whether we need post-dilatation. Looks like we won't need a post-dilatation, but let's look at the, at least can you zero the aortic pressure also? Let's see the gradient first.
Could you talk us through the commercial alignment in
Yeah,
the various views?
sure.
Are you happy with the commercial alignment?
We will check it. So it looks like we are happy. We're looking at that view. This is a coplanar view. And if you look at, this is a valve deployment view. You can see that all the three commissures, the new commissures are equally spaced and looking good. We will confirm it by looking at the cusp overlap view. Come to the cusp overlap view, please. Increase the caudal and RAO.
So what you're looking at are the three commercial posts. So the taller valve frame. Yeah.
So you can see the just below. Can you show the previous image again, please? Yeah, play the last one, what I showed you, the last one. No, yeah. So if you look at the pigtail, which is the aorta, just below the pigtail ring, you can see the three commissures. We can see the dotted markers that are three new commissures, transcatheter commissures. You can see the middle one and the other one. So let's look at the RAO caudal. Yeah, come.
This was the coplanar view, so we wanted,
this is a coplanar view.
We wanted the commissures to be equally spaced. And this is the cast overlap view.
What is RAO?
So for the audience who are not very familiar with cast overlap, what you see on the right side of the screen is the overlap of the left and right casts, and on the left side of the screen being the non-coronary cast.
Yeah, this is the cusp overlap view. So actually, we didn't have a perfect alignment, but we have a reasonable alignment. If you look at the cusp overlap view, what we expect is we want to have only one post on the right of your screen and two on the left side of the screen. Here, if you look at this, you have slightly on the left. The center post is slightly on the left, but not overlapping. So we have achieved a reasonable amount of commercial alignment, but maybe it's slightly malaligned. Okay, now, so look at the echo gradient, please. So see, if you look at the hemodynamics, there is no gradient. And you can see that he's in sinus rhythm.
The QRS is narrow as well.
QRS is narrow.
Would you at this juncture routinely do an echo, or is it based on aortogram?
Can you show the echo?
Yeah.
No, we look at the hemodynamics, then the fluoro, angiogram, and the echo. So we will do the echo now. Show the echo, please. Echo.
So maybe the Achilles heel of this valve may be paravalvular leak because of the radial strength versus a similar balloon expandable valve.
Yeah.
So this is what we will be interested in.
Well, I think the post-deployment echocardiogram, actually I'll show you the gradient first. The gradient is pretty good actually. You can see the maximum mean gradient is about 9 millimeters. And there's also a little bit of an outflow tract velocity. If you subtract that, it's going to be around 6. This is because the basal septum is hypertrophied and coming in. Now I'll show you the other pictures. So this is a parasternal long axis view. Again, you can see the valve and the ascending aorta and the basal septum. So it's just above the basal septum, the lower end of the valve. And the LV function is pretty good, and the aortomyoidal curtain is pretty good. And next, there's not much of... So here you see the four-chamber view, and nicely placed. Here is the basal septum and the valve here. And the next picture, you saw the color flow. Hardly any AR that we could see now, but we'll have to reevaluate. But nevertheless, there's nothing significant at all. Then the gradient, as you saw here, the post-PVC gradient, the outflow tract gradient is about 10 millimeters. But overall, I think it's a very good hemodynamics, considering the narrow LV outflow tract and angulation and small LV.
Yeah,
Thank
can
you.
you come back? So I think overall, I think the hemodynamics appears very good. So we wanted to achieve a good hemodynamics, show the fluoro. So, and absolutely no pacemaker, and we have a good expansion, good circularity, and now we have good access for the future access. So I think we are happy with the overall result, and now we're going to take the sheath out. So do you want to add anything?
It's amazing to see the impact of the TAVI. It's immediate. You see how the pigtail in the ventricle is squeezed by the hypertrophic septum, how the LV is relieved. And it's almost, in systole, there's almost no more cavity anymore. And they typically, as we discussed together, they become so hypertensive after sometimes TAVI. You see how hemodynamics change immediately after the intervention. It's a wonderful teamwork. We are quite impressed here by what you have been doing.
Hello, Dr. Bilu.
Yeah.
I'm Kisun here, a chat moderator from the room. There's a question from the floor that asking that the pacing wire is at the septum, not in the RV apex. He's asking what is your preference of the positioning of the pacing wire in terms of capturing and risk of pacing wire induced perforations.
Yeah, so here we use a balloon-tipped pacemaker. And it's going to be, most of the time, we don't need a pacemaker for this valve. Only for the pre-dilatation, it's very important. So we make sure that we have a good output. We give a good output, make sure it paces well. As long as the pacing wire is stable and it's pacing well, I think we are happy with that, particularly for during balloon dilatation.
Okay, thank you.
For those with experience with this accurate neo, what is the typical pacemaker rates like after implantation? Do you see a high rate of implant of a pacemaker or is the pacemaker rate low? Would you typically leave a separate pacing wire overnight?
We haven't had, I mean, unlike the other devices, self-expanding devices, because you're so certain where you land with this device, we really haven't seen need for pacemakers. And in fact, what we do now, which is in contrast with what we used to do, is that we remove the temporary pacemaker right on the table.
So it will be pacing through the LV or just remove a separate pacing wire without keeping it overnight?
No, we don't longer keep them overnight. As long as there's no QRS changes, the pacemaker comes out. I wonder whether this is also would possibly eliminate the need to use a temporary pacemaker by using the wire to pace the ventricle rather than inserting a new temporary pacemaker.
Yeah, I think for the pacing on the wire, you really have to make the step, and once you have done it and you feel comfortable, you will never use temporary wires unless you have an unfavorable ECG at the start. If you have conduction disturbances in old patients where you expect to be pace dependent, and of course you don't use this, you will put in then we mostly use we ask the electrophysiologist to put in to screw in a temporary pace wire that we can convert to definitive and from jugular to avoid any, trouble later on from the femoral root.
Will anybody cover the issue regarding the cerebral protection in this relatively young young patient with a longer life expectancy?
So, Dr. Velu, the question is
Yeah,
the use of
I heard that.
Yep.
So considering that this was a tricuspid valve, a young patient, and not so extreme calcification of the aorta, we did discuss the patient, and also the evidence is again not very high. With that and the patient preference in the heart team, we decided low risk. We didn't want to do a protection. But in our practice, we're considering it for very elderly patients, valve and valve, bicuspids with heavy calcium. But again, still we have a very strong data. I mean, we're not routinely using, particularly because of the cost issues.
Hi, I'm Sivraj from Singapore. Congratulations, a wonderful case. I just want to ask, do you pre-dilate for every case or just case-by-case basis?
No, for this valve, it's very important that we predilate for all the cases, that too more aggressive predilatation. Generally, for other valves, we use the smallest diameter of the annulus and choose the balloon size. But here, we use the perimeter-derived diameter and then reduce 1 millimeter from that, so which is more aggressive than a routine predilatation. And it's important to do that because this valve doesn't have much radial strength, and this valve has to be if you don't dilate, there is a risk of pop-out, and so it's very important to pre-dilate. So 100% of the cases we pre-dilate, and in some of the patients, post-dilatation may not be necessary. Only hardly in about 20% or even less would need post-dilatation. So if you do aggressive pre-dilatation. And I just wanted to add that the pacemaker risk, particularly for this valve, is much lower. Even though the depth is 4 or 5 millimeters, because it doesn't exert too much force and it's very soft on the LVOT, and hence the risk of pacemaker is much lower despite fixed depth of this valve. Yeah.
Thank you. We do have about 19 or 20 minutes left because the excellent, efficient way that you have demonstrated the valve deployment. But don't worry, this gives us a lot of time to discuss because there's lots of areas to discuss in this young patient. Maybe I could start off with going back to the assessment.
If you have a minute, we'll just show you quickly the commissures. You can see the echo. Sure. I think we're seeing the echo. Actually, we can see the valve commissures. It's clearly not on the coronaries, but it's not a perfect alignment, but you can see that. Yeah.
I think I'm going to freeze this picture. You can see that. So, and then these are the markers that you see for the commercial alignment. Here is the left main coronary artery coming off. The right will be coming off right here. So I think now I'll unfreeze it. You can see that the cusp leaflets are also coming in and out. I adjusted the gain just to see this. But if you increase the gain, you can see the leaflet cup tips also. So this is a way to look at that even. I mean, obviously you have to use the fluoro, but you can see this too.
The fluoro, you can show the circularity. Also, the long-term, the commercial alignment is also helping there are some few evidence suggesting that you have long-term risk of degeneration much lower. The durability is much higher if you have good commercial alignment, as well as getting a circular deployment. I think we saw in this case that the valve was quite circular. We can also show you in extreme angles the circularity what we get. So that is again important, particularly in terms of this young patient to achieve a good expansion and thereby good durability of these valves. Okay. So sorry to interrupt your discussion. Go ahead,
problem.
Please.
Definitely on echo, we see good circularity. And looking at more than 2 angles, we do see that the valve is definitely very well deployed and expanded. The good pre-dilatation probably helped in this aspect as well. Good, excellent hemodynamics, hardly any paravalvular leaks.
Circular connection, extreme angle.
So maybe if we can come back to the initial assessment of the patient, particularly in this young patient, I think the trend may be changing. Previously, coronary angiogram and assessment was routine by invasive coronary angiogram. I may have missed it, but in this patient was coronary artery assessment done in such a young patient. In what way was it done, and what is your routine, Dr. Velu?
Yeah. So we generally do a CT assessment of coronaries as well as the aortic valve and the peripheral arteries. And if we find the coronaries are normal and there is no, particularly when there is not much of calcium, then I think we take that and we don't do an invasive coronary angiogram unless the patient is heavily calcified. Again, in this view, we saw in the iotogram, I think you can see that in the frozen image here. Can you show that image?
The
So we can
coronaries
see the
looks
coronaries were actually looking good in the first iotogram itself. You could see the coronaries. So again, it just suggests that it's normal. But we routinely don't do an angiogram unless there is a suggestion the CT or there is heavy calcification.
Is there an age cutoff that you would use deciding between CT and...
Yeah, we don't do that. We look at mainly the calcium score. The calcium is very high, then we probably do an angiogram. But we generally don't have ages cut off, but I don't know whether, do you do it in your practice?
So maybe I can go around the panel to see what is the current practice in your country, maybe control for TAVI patients pre-workup. Do you routinely assess coronaries?
We try to skip the coronary angiogram as far as possible because mainly there are a lot of elderly patients. And once we have some data about the potential coronary artery disease, we proceed to the coronary angiogram.
Dr. Poses?
Yeah, our population is kind of older, so we still end up doing quite a few angiograms and often find that we do have significant coronary artery disease. In going back to this patient, he is he's a young patient, but he isn't truly a low-risk patient. So it's very important to understand when they are young and differentiate between young and low risk, because he has other high-risk parameters, and importantly, the liver. Yes. And so this patient is a TAVI patient in our center. This would be a TAVI patient, yes. And no surgical option for him, given that we can achieve these kind of results with these devices.
Mm-hmm. Eric, for Europe, for Switzerland?
Yeah, we have another patient population, 75 plus mostly, so they go through angio. A substantial number of them have coronary disease, and there's the ongoing question what to do and how. There is a randomized trial ongoing now, PCI before or after. And because we have another population, essentially in our workup is geriatric counseling. So if the geriatrician say, it doesn't make any sense to put in a TAVI, then mostly at the valve board. I think we have weekly valve boards where we discuss all these patients, not only the aortics, but also their mitral pathology. If the geriatrician turn them down, we will probably not treat them. We listen to them.
Thank you. What about Taiwan and Thailand, Dr. Im?
Well, in younger patients, because they are not covered by insurance, so the CT have a very good negative predictive value. So usually we don't have to do coronary angiogram in every case. But for applying reimbursement, we have to provide coronary angiogram data. So in elder patient or high-risk patient, we need to do that.
We're still doing the angiogram almost routinely, and partly because they were done before the patient was decided whether or not they're going for surgery or TAVI. And our surgeons still would like to get the feel of the coronary anatomy.
Iotogram.
But I agree, I think the need to know exactly what the coronary is less and less important these days, because we know the nature of chronic coronary disease. But I was told that if you were to do a CT of the whole aorta, and in order to see a coronary well, you need more contrast than just to look at the aorta. Is that true?
Yeah. So I think that's is an attractive option, the CT. However, we know that coronary artery disease and such elderly patients that we treat with TAVI often coexist more than 50% if you look at the first generation trials. And the quality of CT in a significant proportion, about 20% or so, would not be adequate. So even though it's very attractive, it may not be accurate, or it may find disease such that we are forced to do coronary angiogram anyway in patients 50%. So to summarize this discussion, I mean, the options of invasive angiogram versus a CT scan versus a maybe stress perfusion MRI that gives us other information such as fibrosis, ischemia pertaining to AS. All these are options, but at the moment, gold standard probably still invasive angiogram, and there is certain attraction of treating these lesions before TAVI valve goes in, particularly taller valves. But the jury is still possibly out at the moment until we have more definitive data. So Dr. Velu, I see you have some slides that is put up. You want to take us through the commercial alignment a little bit more in case we missed it?
Yeah. So I think the commercial alignment is quite simple in this valve. So when you introduce the valve, as we showed, the orientation of the safety button should be faced at 6 o'clock when we introduce it. And then when we take the valve in, just keep the valve, the marker at the upper border of the pigtail, and you can look at the fluoro. As you can see in the slide, if you have 2 on the outer curvature, then you have to do a clockwise rotation. If you have 1 on the outer curvature, 2 on the inner curvature, then you have to do an anti-clockwise rotation. So if you have all 3, you can see all the 3 equally, then it's fine, you can accept it. So this is as we showed, we had 2 on the outer curvature, so we had to do the clockwise rotation. And then you can confirm that in a cusp overlap view. And after alignment, you will see just 1 commissure on the right of the screen, on the left side, that means left side, but right of the screen, and 2 on the non-coronary side. So that means we achieved a 100% commercial alignment. And the objectives, mainly in this case, I think we achieved what we wanted. In a young patient, the durability is a main importance. So in that, we have make sure that this patient has not only commercial alignment, but also very no AR. So again, we know that even a mild PVL has long-term consequences with the new evidence showing that has increased chance of valve failure in the long run. So I think I want to again emphasize that in this patient, no, that's fine, not the slide. So in this patient, I think we should ensure that we have ensured that we don't have a pacemaker, we don't have a PVL, we don't have any patient process mismatch, we don't have we have a commercial alignment that we have achieved, and I think and coronary access is going to be there. So I think we achieved what we wanted, and we have closed it with the final closure is again I wanted to show. Can you show this, please? So we used 1 single ProGlide at 12 o'clock.
Switch to the cath lab view? Yeah, thank you.
Yeah, can you show? So we just put 1 ProGlide, and the bleeding stopped. Can you show it in a bigger screen? Nice. Take the slide off. Can you show it in a bigger screen? Yeah, show the video, please. Show the camera, please. Show the camera. So can you bring it, lift it and come show it. Like,
maybe remove the tower. Yeah.
So I think we are not able to see better. No,
So this is just
so actually
1 ProGlide.
It's just 1 ProGlide and there is absolutely no bleeding at all. Show this. Not here, this one. Show this.
Yeah.
Show here, please.
Yeah, we can see
so
it.
I think he's not, I don't know.
Yeah, you can see
I hope you're able to see it.
results.
Yeah, we have sutured the skin incision as well. So I think there's no bleeding at all.
Great results.
Yeah. You gave some protamine half dose at the a question for the group here, because this practice is very variable from place to place.
Yeah. So is protamine routinely given at closure? Yes.
Yeah.
Yes.
Yes.
Yes. Yeah.
How much?
How much?
Depends on how quickly you do your TAVI. and we just guesstimate the number, half, 3/4, 1/4. But we also use single ProGlide for the 14 French. And if not successful, then additional of 1 angioceal would usually work.
One issue which we don't talk is you start your TAVI and everything goes wrong because you have trouble with the ProGlide. because we have, at least in Europe, some patients that are a little bit overweight, and we have to go through 3-4 centimeters of fat under the skin. So you know when trouble starts is when your proglide starts to bend, and by that moment you're lacerating your femoral vein, and then you get into big trouble. I don't know if this is something that also occurs in your. What I do in this case, I use the advantage wire, curved advantage wire, which gives you the advantage to go in with the advantage wire along with the proglide to avoid bending of the proglide, because once your proglide is bended, then you can be in big trouble. I don't know if you have encountered this problem too.
Yeah, but perhaps the problem is not as acute. It's getting worse because the obesity rates are going high in Singapore, but perhaps not as big as Europe. But we anticipate this based on the BMI. And if we do see the patient is rather obese, we first fluoro, when we do any exchanges, particularly of the proglide, we will use longer wire rather than the short wires. And if we do anticipate that we need support, then it will be the stiff wires that we exchange this proglide with, always under fluoroscopy, because that's where the entry point usually causes the buckling of the proglides.
Do you use MANTA device in Singapore?
Yes, for a while. Then it got very expensive. And unfortunately, with the smaller vessels, what we do see is a lot of vascular complication because the foot plate is particularly big, and it does cause a lot of intersusception. So, I mean, I know there are lots of papers published to see, based on ultrasound, how we can accurately deploy this MANTA, but we have stopped using MANTA because of our experiences. I don't know about the rest of the sensors. Anyone with MANTA experience? No. Okay, so we have about 4 minutes left. I think this particular patient, a burning question I have is what to do when this initial TAVI valve fails. I suppose he may have lowered life expectation because of his liver disease, but assuming he's going to live to 80, and the valve starts degenerating at 70 years old, still relatively well, still have liver disease, the options of a TAVI explant versus a TAV in TAV. So surgeon, again, TAVI explant.
I think we were discussing this on the way here with Dr. Ho. TAVI explant, any situation is terrible, and especially with a balloon expandable, where it lacerates a lot more intima in the aorta. So, I mean, microscopically, we're not sure. Macroscopically, it looks terrible, and we're always worried whether it's going to rupture or whether we consider doing Bentol at the start. So, if this patient had gone for TAVI, that means the risk factors prompted TAVI. So, if it's going to be subjected to a bigger operation when it's older, with more comorbidities, I'm not too sure whether TAVI explant, especially all of us with armed with TAVI technology today, and it's going to improve in another 10 years' time. So I think explant may not be a great option.
So maybe a quick question, we have 2 minutes left before we change over and submit. What would be your choice in a TAV and TAV if you do have to resort in TAV and TAV? The platform of choice of use.
I think currently, if you look at most of the literature, and I'll say I have not had experience with accurate TAV and TAV, but for most of these self-expandable supraannular valves, shorter frame valve like a balloon expandable one would be the best. You allow some leaflet overhang so that there's still access to the coronaries, and I think at least with current evidence, that will be the way to go. In 10 years' time, we don't know. People are experimenting with leaflet laceration devices and all that. So I would think in the next decade, we may see actually huge advancements in this field.
Thanks, everybody. I think we have come to the end of this session, at 3 o'clock. We thank Dr. Velu and excellent team and presentation. I'll have Dr. In do a short summary before I pass the time to Dr. Velu for closings.
Thank you. Teams from Apollo Hospital demonstrate an excellent case regarding lifetime management of a younger patient. From patient selection, device selection, and also pre-procedure planning, execution of the precise execution of the procedure, and post-TAVI evaluation. We learn a lot. I think all of you agree that this is a very fruitful session. Thank you very much for your attention.
Thank you, Dr. Velu. Thank you for the excellent presentation.
Thank you very much. Thank you, Professor Ko, and the Singapore Live organizers and the chairpersons, moderators. Thank you very much, and see you in Singapore sometime.
Okay, thank you. It's been an excellent session. Thank everybody for your attention.